It is an honor to introduce my dear friend Peter Angelos to you as the 2014 Poth Lecturer. The title of his talk today is Surgical Ethics and the Challenge of Surgical Innovation.
Well, good morning. Ken, thank you very much. I really cannot tell you how honored I am to be here and to be here when you're the president. And thank you all for being here this morning. I realize that I stand between you and coffee, and so that's quite a challenge. So I'm going to do my best to move along and keep you awake. Okay, I have no disclosures. Thank you very much, Chris. I'm going to talk a little bit about surgical ethics, and I'm going to try to move rapidly because once you start talking about ethics, the natural response for most surgeons is for their eyes to glaze over. I want to talk a little bit about innovation because I think innovation is absolutely critical to what we do and for the future not only of our profession but of our patients. And I want to talk a little bit about professionalism because I think that this is a topic that these overlap tremendously. And as Ken mentioned, I'm an endocrine surgeon, so I have to use an example of something that I know about, and I know about very little. So I'm going to talk about thyroidectomy because that is something I know a little bit about. So in terms of surgical ethics, I think many people sort of hear this, and perhaps less these days, but 25 years ago when I was applying to surgical residencies, and I said, yeah, I'm really interested in surgery, and I'm interested in ethics, and I was, in fact, as Ken said, getting a PhD in philosophy, and not a single program director or chair actually asked me about that. It was much as though I had said I was interested in modern dance. That was about the level of enthusiasm for questioning me about that. The only person that actually did ask me about it was David Narwhal, and that may have something to do with the reason why I matched at Northwestern. But many people sort of see surgical ethics and they say, well, I don't know, medical ethics, I'm familiar with that, but surgical ethics, is that an oxymoron? And some people have said, well, surgical ethics is kind of like jumbo shrimp. And, or others have argued, well, it's kind of like military intelligence. And I would suggest to you that neither of those is in fact accurate. And although I don't really have time to make a clear argument for this, I would say that there are in fact three significant differences between surgical ethics and medical ethics. And I won't spend a lot of time talking about them other than to just mention, I think that the nature of informed consent for surgery is very different from informed consent in other areas in medical care. The fact that a patient is willing to lie down, be in a completely vulnerable position, in my case, frequently allow me to cut their throat, is a significant level of trust that our patients place in us. And I think that that level of trust is something that changes informed consent in surgery. And so I think we do it all the time. We almost forget how big a deal it is. But I think we ought to pay attention to that. Secondly, the nature of responsibility, I would argue, in surgical care is different from in other areas in medicine. And again, it's a sort of a complicated thing to present in a short period of time, but I would suggest that the best example or illustration of this is from a book by a sociologist named Charles Bosk called Forgive and Remember. And some of you may be familiar with it. If you're not, I would encourage you to look at it. It's actually a sociological study of surgical residency training program. And Charles Bosk was a graduate student at the University of Chicago. And so he did his field work at the University of Chicago, where I'm now on faculty. And so there are surgeons, they're all pseudonyms. He never tells you where it is in the book, but those of us who are there actually know who the surgeons are that are described in the book, and some of them are still practicing. So anyway, Charles Bosk said that he was interested in M&M conferences and how error is addressed, and he said that when the patient of an internist dies, colleagues ask, what happened? When the patient of a surgeon dies, colleagues ask, what did you do wrong? And that, I think, is an absolutely fundamental and critical difference in how we think about our responsibility for our patients. And I would argue that that's different in surgery than it is in other areas of medical care. And then finally, I would suggest that surgical innovation is different because there is nothing like an FDA for surgical techniques. If we think that doing something differently in the operating room is going to benefit our patients, and even if we've never seen anyone else do it that way, we're not only allowed to, but we're expected to exercise creativity on the part of our patients to benefit them. And that level of flexibility in what we do is, I think, critical to surgical innovation and surgical progress. And there's really no oversight. So this may be a good thing or a bad thing depending on how you look at things, but I would argue it's very different in surgery than in other areas of medical care. So let me take just a moment and talk about professionalism. Now, professionalism is one of those things like, apple pie. It's really, everybody's in favor of it. It's like, I say, well, I'm interested in ethics, and people will say, me too, I'm all for ethics. Very few people are opposed to it. Professionalism in medicine has lately really come, it's sort of exploded. And I looked at a number of books recently: Professionalism in Medicine, Measuring Medical Professionalism, Teaching Medical Professionalism, Educating for Professionalism, everything, lots and lots about professionalism. I was still having difficulty, though, finding a good definition of professionalism because many of them are somewhat circular. I did find one that I thought was really helpful, and again, not to spend a lot of time, I'll just share with you what I think is a good definition. This is from the Canadian Journal of Surgery. And Dr. Christian said, in return for professional autonomy, self-regulation, and a recognition of their unique place in society, the public demands of physicians accountability, ethical standards, and an altruistic manner of delivering care. And you see, I've circled the things that I think are really critical for us to keep in the back of our minds as we talk about innovation, and that is self-regulation, ethical standards, and altruism. I think that these are all critical to our professionalism. So let's talk for a minute about innovation in surgery and why that's important. And I think, most surgeons would say, of course, innovation is a good thing. I like what Henry Ford said: if you always do what you've always done, you'll always get what you've always got. And so there is a sense in which you've got to do something different. You've got to be innovative, or else there's going to be no change and no progress. And I would argue that how we do almost any operation today has changed. And if it hasn't changed, then we're doing it the same way we did decades ago, and that's not usually beneficial for our patients. I would say innovation is the result of creative attempts to solve individual patient problems. Now, sometimes innovation is, the light bulb and someone completely changes the way they do something. But often innovation happens as a result of small changes that allow us to move towards something beneficial. I would say I and most surgeons would agree that innovation is the way forward in surgery. This is what's going to make things better in the future. Now, unfortunately, new ideas aren't always good ideas, and there's lots of great examples of that from the historical record. I'll just mention a couple. Transplanting goat testicles into humans. This was all the rage at the early 1900s, and if you're wondering to yourself, well, why am I unfamiliar with this tremendous medical advance? It's because it doesn't work. It's not helpful. So it was used as a treatment for impotence, and then the thought was, well, it could work for women too if they're tired and didn't have a lot of pep. Well, and then pretty soon everybody was getting goat testicles transplanted, but it's not effective. This is a great book I would encourage you to read. A few other innovations that were not advances for patient care that are perhaps a little bit less out there: internal mammary artery ligation to treat angina. Again, the idea was, if patients have angina, it's because of lack of blood flow to the heart. So if you ligate the internal mammary artery, you'll push more blood into the coronary vessels. Seemed like a good idea. Thousands of patients had the operation. Lots of surgeons, in fact, very well-respected academic surgeons made their reputations doing this operation. It is, in fact, not effective. There's lots of other examples. One that's sort of near and dear to the heart of an endocrine surgeon is radiation to treat acne. Now, that's not really a surgical advance, but let me tell you, radiation was used to treat everything: enlarged thymuses, acne, asthma, ear infections, enlarged tonsils. And I'm still operating on patients today that got radiated as kids, and now they have thyroid cancer and hyperparathyroidism. So again, it was thought to be a tremendous advance, didn't turn out to be that way. So I would say that this leads us to this question, which I think is a fundamental question that we don't often give enough attention to, and that is, how do we decide if an innovation is actually an advance? Right? So we do something different or new. The assumption in the public is, well, new and improved. And I think often we assume if it's new, it's better. But how do we really decide if something that is new is actually better? And so again, I hope you'll bear with me, and I just want to very briefly talk a little bit about the history of thyroid surgery. And many of you are familiar with this portrait. This is the Gross Clinic by Eakins, and the gentleman who is regally portrayed in the center there is Samuel Gross. And Samuel Gross was one of the most influential surgeons in America. In 1866, in his textbook of surgery, he wrote, and I'll read this to you because it may be hard to read from the back, "Thus, whether we view this operation," this is thyroidectomy, "in relation to the difficulties which must necessarily attend its execution, it is equally deserving of rebuke and condemnation. No honest and sensible surgeon, it seems to me, would ever engage in it. Can a thyroid gland, when in a state of enlargement, be removed with a reasonable hope of saving the patient? Experience emphatically answers no. If a surgeon should be so adventurous or foolhardy as to undertake the enterprise, I shall not envy him. Every stroke of the knife will be followed by a torrent of blood, and lucky will it be for him if his victim live long enough to enable him to finish his horrid butchery." Now, let's think about that. We don't see this kind of writing in the surgical literature today, right? It's all about, p-values and graphs and what. It's not horrid butchery. It's not torrents of blood. Now, partly that's because, styles change, but also the operation's gotten better. Now, I don't think any of you have been in the operating room with me when I've done a thyroidectomy, but it's not that bad today. And I rarely even use Cell Saver. That's a joke, okay? I don't use Cell Saver, in case you're not sure. You're like wondering, is he really serious or not? That's a joke. So obviously things have changed. And what changed? Well, lots of things, but Coker in particular proposed lots of changes in how thyroidectomy should be performed, and Coker wound up being the first surgeon to win the Nobel Prize in Medicine. Now, in recent years, there's been a movement in surgery in general towards minimally invasive surgery. And that, endocrine surgery, thyroidectomy is no different from anything else. Lots of innovative approaches to thyroidectomy. Now, as an aside, I think it's fascinating that in other fields of medicine, for example, GI, everybody wants to be maximally invasive. So I say to a gastroenterologist, "Oh, I didn't know you were a gastroenterologist." And he says, "I'm not a gastroenterologist. I'm an invasive gastroenterologist." And cardiologists say, "Well, I'm not just a cardiologist. I'm an invasive cardiologist," right? "I'm not a radiologist, but I'm an interventional radiologist," right? But surgeons, we don't want to be surgeons. We want to be minimally invasive surgeons. Now, I'm not sure exactly what that says about us, but I think it is a commentary that we have to pay attention to. But with respect to thyroid surgery, there was this idea that, well, we should do something to avoid the disfiguring scar on the neck. And so I won't go into a lot of detail, but this was an early approach from 2000 This is an axillary thyroidectomy approach, and it's done with, laparoscopic type instruments, some endoscopic instruments, and so the patient's head is off to this side here, feet down here, and the patient's arm is up over the head, so that shortens the distance between the axilla and the neck, and so you can do a thyroidectomy in this fashion and avoid a scar in the neck. And people said, well, gosh, if you can do it through the axilla, how about going through the chest wall? And so this was another early approach with incisions near the xiphoid and periareolar incisions. And of course, as most surgeons think creatively, say, well, gosh, we could put that together and we could do the bilateral axillobreast approach, right? So this was the BABA approach to thyroidectomy. Now, I can tell you that this really did not take off in the U.S. And I'm not sure, but many of my patients are women, and for a woman to come in with a 1.5 centimeter indeterminate thyroid nodule, and for me to say, good news, we'll avoid that 4 centimeter incision in your neck, but I'll make 4 incisions, 1 in each axilla, 1 in each breast, didn't really engender a lot of enthusiasm. But nevertheless, it is effective. And then I think most people have heard of, and there was at the endocrine course, one of my colleagues gave a great talk about alternative approaches to thyroidectomy, robotic-assisted axillary thyroidectomy. The idea being that, well, you take that, the axillary approach, but, you use a robot, and then, of course, that changes things and allows, all those degrees of rotation, et cetera. But at this point, people were sort of wondering, well, what about Notes thyroidectomy? And I have to honestly admit that this was a time, I had this as a slide years ago in a talk, and that was the punchline, Notes thyroidectomy, and everybody laughed. But in fact, this has been done, and the idea is that you can avoid any visible scar at all by going through the floor of the mouth and dissecting straight down. You've got a really nice view right down on the thyroid that way. And if you think that this looks great, think about if you added a robot. And so these are now all different approaches to doing a thyroidectomy in, now if are they minimally invasive or not? Well, we won't talk about that, but I can tell you that they are innovative approaches to thyroidectomy. So the question then is, are these approaches progress? There's little change in morbidity. There's no change in mortality. The only difference is a cosmetic difference. And so the question, I think, is a cosmetic difference any less important than other differences? And I would argue that that's not a question that we can readily answer as surgeons, because whether something is considered to be progress depends on what we value. And what patients value may be different from what we value. And so this is something where I think we have to be careful and not jump to conclusions on either side without carefully assessing patient values with respect to these operations. Now, I do think there are some specific ethical challenges associated with surgical innovation. And again, thinking about thyroidectomy and the little, the historical tour that we just took, I would ask you to think a little bit about some specific issues. So one is informed consent. So I mentioned that informed consent in surgery is a critical differentiator between surgical ethics and medical ethics. Well, when it comes to innovative procedures and innovative techniques, I think informed consent becomes particularly challenging. Mark Twain said, "It ain't what you don't know that gets you in trouble, it's what you know for sure that just ain't so." And in fact, that applies to much of surgery, right? We know what the risks are. We know. But if something's really innovative, we often aren't 100% sure. And if you think about something like thyroidectomy, and you say, okay, thyroidectomy, it's a low-risk operation, 1 to 2% risk of permanent hypoparathyroidism, 1 to 2% risk of permanent nerve injury. So if you said, well, I'm going to utilize this innovative technique, and I'm now presenting it to my patients. And I've done 100 cases. And I say the risks are no different. This alternative, innovative approach versus my conventional approach. Well, I would say after 100 patients, saying there's no difference doesn't mean anything. In fact, after 500 or 1,000, because we know from low-risk things and the way numbers and statistics work, we would have to do thousands of patients in order to show if there's any change. And so I would argue that we can't really know what the true risks of a new thyroidectomy technique are at the outset. And we can't know probably for years unless we're all pooling our data and looking at many, many more large numbers. So I think that's a challenge. How do we disclose risks when we don't really know what they are? Well, that's the challenge for explaining uncertainty. Well, what about patient safety? So certainly if I think, well, this is a really good operation and, I've got a little bit of experience with it, we know that I'm not going to be as good if I've only done 10 of them as if I've done 100. We also know that I may be better after 500. Now, we all understand the learning curve, but I'm not sure that our patients do. And so one question is, should this be discussed with patients? And I think most people would say yes, and if so, then the question is how? Now, I have to admit that early on there's a different technique which I didn't have a picture of, which is called minimally invasive video-assisted thyroidectomy. So you just make a smaller incision, you use a little camera and a scope, and you do the operation. And the first time I was offering that for a patient, I've been trained and everything, and I said to the patient, we could do this, you'd be a good candidate. And she said, well, sounds great. How many have you done? And I said, well, you'll be the first one. And boy, let me tell you, if any surgeon ever said that to me, I would be out of there so fast. The patient said, really? I'm going to be number one. And I said, yes, you are. And she said, that is so awesome. I am so glad I can be your first patient. Now, I'm not, like I say, that's not how I would have responded. But I think that we at least have to be honest and upfront and, let the chips fall as they may. Well, let me ask another question, which I think is in fact a whole series of questions, and that is, can surgeons and patients objectively assess the benefits of new procedures? And so I want you to imagine a surgeon in a Midwestern city, such as Chicago, who has decided, as much as he hates the concept of doing an operation through the axilla with a robot, maybe I got to learn how to do this because, I don't want to be a dinosaur too young in my career. And so I thought, well, I want to learn how to do it because I don't want to be critical of something when I don't really even understand it. So I did robotic training and I did a cadaver lab and I went to see surgeons doing it and, I did all kinds of things. And then, so, a lot of time and effort, money spent in learning how to do this, okay? So now I'm ready. I'm ready to do the procedure. Interestingly enough, I have a rep who sees me every couple days and says, so, Dr. Angelos, have you got a patient? Have you got a patient? We're ready to support you. Have you got a patient? I didn't have a patient. Now, on the other hand, you got patients who are reading things on the internet. And so one day my nurse called me up and said, Peter, good news, I got a patient. She called from Wisconsin. She asked if you do this robotic axillary thyroidectomy. And I said, yes, and she's very excited to come see you. And I said, great. So, I'm going to see her. I see her, we have a nice conversation. She's all excited about this operation. She's like, I looked all over for someone who would do this robotic-assisted axillary thyroidectomy because I've read on the internet it's so much better. And so, I'm sort of trying to be, trying to control my enthusiasm, right? My first patient. And at the end, I said, as much as you really want that operation, you actually don't have any indication for surgery. And she said, but I want this operation. I've read about it. Now, obviously surgeons have different opinions. She said, well, another surgeon told me I needed an operation. I said, well, then you can see that surgeon. But I really do think that in a situation where you have a surgeon who's all primed and ready to do this innovative thing, and you've got patients who have read the hype about some new procedure and are convinced that it is correct, that significantly changes the dynamic of informed consent. Generally, if I'm recommending a thyroidectomy for someone with thyroid cancer, they don't really want the operation. Now, it's not that I'm excited to offer them, but that's what I do. And so they may not want it, but they understand they need it. And so, I talk about risks and benefits, and, we come to this agreement and they sign up for the operation. I think if the surgeon is totally into doing the operation and the patient says it's the best thing in the world, I'm not sure that dynamic is conducive to the most effective and honest communication. Well, what about ethics and costs? So, we know new technology is more costly than the old technology, and innovation is usually dependent on this costly new technology. We also know that operative time is very expensive, right? Lots of places operative time is the most valuable thing in the hospital. And new things take longer. So, and I can just relate to you my early experience as an intern standing in the back of the room when the first laparoscopic cholecystectomy was done at my institution. And I won't mention the surgeon who did it. He's a good surgeon, young surgeon, went out, learned this technique. So I could tell you, I'm one of the interns standing in the back of the room watching this historic new operation, the laparoscopic cholecystectomy. And so after about an hour, they got the first trocar in. And I thought, I don't know about this operation. And after a couple hours, we were starting to see the cystic duct. And after about 4 hours, I was honestly praying that my pager would go off so I could leave the OR. Now, it took 5 hours. It was effective, right? It took 5 hours. Now, if at that point we had said, boy, this laparoscopic surgery is ridiculous. It takes too long and it's too expensive, we would have said, we're not doing it. We would not have jumped on this laparoscopic bandwagon. The problem is that things change and we get better at some things, and so early impressions can be completely wrong. The problem is, though, that we don't really know when to jump on the bandwagon. There's not a lot of good, there's not a lot of scientific evidence that allows us to say, well, this is something definitely we should do. We should keep doing this, even though it may take a long time, because eventually we're going to get better and it's going to pave the way to lots of other things. We don't know that up front. So we've got to sort of go on faith that some things we're going to pursue because it's going to get better and others we shouldn't. So I would share with you a few concerns. I think that individual surgeons are faced with the challenge of determining what innovative techniques should be offered to our patients. I think sometimes the innovative technique may appeal to us. It may be very gratifying. It may allow us to use new technology which is interesting and challenging and fascinating. I think often when patients see something described as innovative, they assume it's better. And they want the latest and greatest because it's America. Now, I think both parties often have this incentive to pursue an innovative procedure without a whole lot of evidence of benefit. And that's something that I think we have to be cognizant of and careful about. So let me just for a moment bring us back to professionalism. I mentioned professionalism and I gave you a definition. Well, I think professionalism is important for innovation. There is no group or institution that determines whether new technology or new procedures benefit our patients. And as a result, the professionalism of surgeons is necessary to ensure that what is new is not automatically assumed to be improved. And I'm not someone to argue for oversight. That's not what I would argue will help things. But without oversight, which is the way things are now, surgeons have to make individual decisions about what to offer our patients. So How can these ethical issues in surgical innovation be managed? Well, I think that the first step is thoughtful self-awareness. I think we have to think about why we do the things we do, and we have to think about what the challenges are. I think that we need to be clear when we're obtaining informed consent from our patients. If it's an innovative procedure and we don't know exactly what the risks are, we have to disclose the uncertainties. And I think disclosure of uncertainty is a really difficult thing for all physicians, and in particular surgeons. And I think perhaps most importantly, surgeons have to gather data to determine if patients truly benefit from surgical innovation. So I don't think it's enough, as we often used to do, to just measure our incisions and say smaller incision, better operation. I don't think it's enough to just simply say fewer incisions, better operation. I think we have to look more carefully at what is it that's important to patients. And so patient-centered outcomes become so much more important and more challenging. So I have a few conclusions. Now, I learned a long time ago that when you give a talk, usually after the introduction, everybody goes to sleep. But there's this automatic thing that when you say I have a few conclusions, everybody's head goes up. And for just a few minutes there, you have absolute attention. And so I have learned that if I put about a third of my talk in the conclusions, it goes so much further in terms of retention. So I've got about 15 more slides and then we'll be done. That's a joke. I don't. Two conclusions. I think that not all innovative techniques are good for patients. I think we all realize that. We see things that other people do and we say, I don't know, I'm not sure I get it. I think the potential benefits of innovative techniques have to be carefully balanced against potential surgical risks. And again, if we don't know for sure, we've got to make some good educated guesses. We've got to exercise clinical judgment about what those risks are. I think surgeons absolutely have to engage in clinical trials or registries in order to assess risks and benefits. And in order for informed consent to be a reality, individual surgeons have to honestly discuss the uncertainties with their patients and disclose that uncertainty, say the things that we don't know. I think we must ensure that new innovation benefits our patients and not just us. And I would argue to you that that is really the epitome of professionalism, that it benefits our patients and not just us. And so I would suggest to you that innovation is both the key to surgical progress and the greatest challenge to the professionalism of surgeons. I cannot tell you what an honor it has been for me to give this lecture, and I thank you very much for your attention. Thanks.
Peter, as usual, thank you for a thought-provoking and provocative approach to ethics and innovation. But it's been great to have you here, and it's always an honor to have you as a friend.
Thank you. Thank you very much.
This is the medallion of the Poth Lecture. I actually own one myself, so.
Thank you very much.
So we have a break and we'll reconvene here at 11:30. Please stop next door and spend some time with our industry partners and looking at the posters again, and we look forward to seeing you back here.